meeting number 78, North East Essex CCG. Last meeting of this financial year, which originally was meant to be our last meeting, but subject to what's happening with government, I think we're temporary stay of grace. Is that the right word? I think. So, apologies of absence from Dr. Prashant Arora, Pam Donnelly, and Patrick Higgins. I believe no one else that I'm aware of. Sorry, Higgs. Got confused with Alex Higgins. It's just back in the day. Any declarations of interest, new or relating to anything on the agenda? Anyone? Max, did you want to declare a role just for?
I probably just need to sort of just generally declare an interest.
Yes. If you could.
I mean, I'm obviously taken on a new role. Actually, from the beginning of February, not January, as is reported in the papers. The papers today, I mean, taking on joint divisional director with Dr. David Gannon for community services, which was being hosted or run by SNEFT. So I have an interest in items that relate to SNEFT, as I'm being employed by them, and I have got that declared on my new declaration of interest.
Thanks. I won't ask you again now you said it, but congratulations on the appointment as well, by the way.
Thank you.
Good news for us. So minutes, please. Can I ask everybody to go through the minutes for accuracy and content? Content and accuracy. If everyone's happy, we'll take that as agreed. Off at the you're not on mute, Lisa.
Sorry.
That's okay. Just thought I'd tell you before you make some other inappropriate noise. Right. So let's move on. So we'll take that as an accurate record of the minutes. Let's move on to the action log. So item 1's on the agenda. Item 2 or 1291.0. That's also in the IPR. I don't know whether you want to say anything else, Pam.
No, we're starting to incorporate more of the Alliance sort of reporting into the IPR. You'll see more as we gather pace, and it was in anticipation of a July start when we'd have the Alliance-based quality committee in place, but we're working into that place now.
Okay, and as I said, for the action, it's on the it's in the IPR.
It is, yeah. Absolutely.
And Lisa, you didn't get back to me about the East updates. I don't know whether you got anything to say now or.
Yes, so I raised it with East, Hassan, the specific example you gave and the wider context of needing to have a clinician contact within the coordination centre. So they are going. I'm just waiting for them to give me details, because the way that East reflected it was they thought that you should already have those contact details to be able to have that clinician to clinician discussion with East, but I don't think you probably do. So I'm just waiting for them to clarify, but then they're very happy to have a clinician to clinician discussion, and they're also very happy to look retrospectively at that specific example, Hassan, if you would like them to.
Yeah, I mean, I think the question really is more around a forum for us to have those sorts of conversations, because there's, since then there's some ongoing things that happen, and it's just really, unless you've got that opportunity to have a discussion around, well, look, why did this happen, then they can't really learn from it.
So we have so we have the clinical forum, which Mark has also asked that we have another one which East will be at, so maybe that would be helpful. But with regards to the specific escalation where you feel there is risk, that's I'm just waiting for them to send me the contact details so I can share it with the primary care.
Thank you, Lisa. So we'll close that action and you'll get back. Yep, okay. That's the log. So over to you, Ed. Thank you.
Thank you. So I'm sure all of our thoughts are with everyone impacted upon by the conflict in the Ukraine. There's an absolutely desperate situation there, and just wanted to provide assurance that in Essex, we're working with all partner agencies to ensure that we welcome any Ukrainian families and people locally, and ensure that we work doubly hard to create good access to healthcare services as of when they arrive. Secondly, in terms of integrated care, so we've had the government's white paper on integrated care that's been published, which places great emphasis on place-based working, or alliance working as we call it. I think North East Essex and the governance and the leadership developed there fits perfectly with the vision that's been set out by the white paper. So we could continue to move forward at pace consequently. Also, there's been a government white paper on levelling up published, which again has a lot of relevance for us with our communities, and Essex County Council and others are leading a levelling up strategy, which has a particular focus on some of our deprived communities in North Essex. In the papers, we've got a really helpful alliance update, and I just wanted to flag the fact that Essex University have launched the Institute of Public Health and Wellbeing, and Pam and colleagues working very closely with Essex in a number of ways, actually. So we'll get to hear about that either today or at a future meeting. But some really great work with the local universities, I think, is now developing around health outcomes. The next thing is our finance team have been recognised at the Healthcare Financial Management Association Eastern Branch Awards, and particularly well done to Emily Bosley. I can't remember the exact category that she won, but I think it was sort of the upcoming star of the finance world in the east of England. So really, really great that Emily was recognised. As we'll see from the agenda, operational performance is very challenging at the moment, particularly because we're seeing rising COVID infections in the community, and that's affecting not only people's health but also sickness rates within our providers. So a big challenge there. The planning guidance that's been published has asked us to clear 104-week wait by the end of June, which is probably the top priority in that guidance at present, and we're making strong progress towards delivering that milestone. And there's also a significant emphasis at the moment upon ambulance handover delays and ambulance response times being critical for obviously quality and safety, but a marker of how a system is working together. The final thing I want to say is that we'll have seen in the national press the public inquiry into the deaths of people who've been cared for by mental health trusts in Essex over the last 20 years. We of course will absolutely support that inquiry as it develops and as we're required to do so, and all of our thoughts are with all of the families who've been affected over that period of time. Thank you, Chair.
Yeah, and can I echo your sentiments with regards to all those difficult things happening over in Ukraine. Max, question.
Yeah, I think when I first started in the health service, which is quite a long time ago now, it was routine to wait more than 2 years for a hip replacement. We seem to have gone back to somewhat similar to that position, which is very sad to see the situation we're in now, of having people having to wait more than 2 years for a procedure. And I do hope that we can turn that round and focus on getting that turned around, because it's simply not acceptable for our population to have to wait so long to have such procedures.
I agree, Max, and Paul, I'll bring you in, but you've got your integrated performance report that you're going to talk to as well later on. So,
I can wait.
Why don't you save it till then? Thank you, Max. I share your concerns, and I think, as I said, hopefully we'll have more of a conversation about waiting times when we get to the performance report. Was there anything else, Max? So you still get your hand up. I'll put it down. Anyone else? Okay. All right. Well, then let's move on to the papers. Thank you, Ed.
Yeah. Did you want me to talk through? Did you want me to talk through this as it was the action?
Yep.
Yeah. Okay. So there've been a number of questions about how we're going to engage going forward, and Myrna, it's refreshing to see your report from the health forum, because it feels like we're starting to connect with what the future looks like. But I obviously don't want to take your thunder with your paper, but what I've tried to present with the team, the engagement team here, is a truly different way of how we will use co-production at alliance level to get the voices from our communities up into informing our commissioning and design through the integrated teams and at neighbourhood levels, and building on the good work that the Health Forum has provided for us for future, but to really fit this into the structure of the alliances for the future. So this will report into the quality committee. It will work with safety advisors so that we can make sure that we're triangulating the voice of the citizens through all of the services that we represent. We've got a much bigger opportunity to get a triangulated view of what's going on, because the way the alliance works, there's many engagement officers, not just for health, but for districts, boroughs, for all sorts of things, and we will use all of that intelligence to inform the work that we've done. I think for us, this is absolutely, it's a game changer. We've never had the luxury of working in that way before. And we know if we take a truly wider determinants of health approach, that if somebody's struggling with housing and they're struggling with access to their GP, that actually in order to make them well, we need to deal with both of those aspects, not just one of them, and one actually drives activity into the other. So this is the approach that we'll take, delegated from the ICB, because Lisa is actually the nominated officer that has a responsibility for engagement, but the delegation of that engagement will come down to the alliance so that we can ensure that it's a bottom-up voice. Lisa, did you want to add anything particularly around the sort of the principles of engagement that we've covered in the paper, so that we're all taking sort of a really unified approach, set of common values to engagement?
Nothing particularly to add, because I think it's a great paper, but I think this is just a really helpful example of how we can all work together in the future with the kind of the strategic direction, and then the alliances taking their own individual approach within that direction. So thank you, Pam, and I think it's a great direction. Thank you.
Thank you both.
Thank you for your support, Lisa.
Questions, comments? Mark, did you want to say something? I'll bring Martin in person. Martin?
Yeah, I was going to say, I think it might have actually been Pam that ran a stat through the F&P committee once that says that you receive 80% of your NHS care in the last 2 years of your life on average. I don't know if that stat still holds true, but it seems to be that most people are, unsurprisingly, therefore, tend to be much older that get involved in from the public whenever we consult. I contact a lot of people in Harwich, and usually they come to me if they're not happy with something, but I always try to get them involved, see if they can get engaged within the process. And I struggle to get younger people to do it, whether they feel that they're well and generally don't want to get involved. And they all say the same thing to me: Mark, why don't you just get on and just deliver a top-rate service? I don't want to talk about it, just get on with it. So are we having any luck getting much younger people involved in the NHS?
So you can see within the paper that it is absolutely all age, and we are taking a different approach through engagement. I think the voluntary sector helps us significantly with that. So statutory organisations don't have much relevance to younger people necessarily. we tend to get a change when we get past the maternal years, and there's very good engagement at that point, and for younger parents. But the children and adolescents, that has always been a challenge. But as I say, a lot of the charities that we're working with, and because this approach will be levered through our community leaders and our charitable sector, they go out on our behalf, and that's part of the beauty of the Alliance, that we don't expect people to come to us. We go via all those charitable organisations where they're meeting youth groups, those sorts of things, and actually it's much more effective.
Great, thank you.
Lisa?
I think there are some good examples where there are very specific areas that children and particularly young people are supporting. So in the SEND programme, there is some really clear involvement from young people. But I think one of the strengths is where young people aren't just focusing on health, but they're looking at how the system works. Certainly in Suffolk, we had a great presentation around the Youth Ambassador programme that works across health and care, or has predominantly been care, but we're looking at how they can support in health. And then also a number of our providers, so ESNEFT has a really good children and young people involvement forum. So I think there's something about how we network into other groups that are already there, but children and young people tend to have quite a transient involvement with health, fortunately. But yeah, I agree. It's hard sometimes. We have the same problem with maternity services. People are transient through that service, and getting a long-term involvement can be challenging.
Mark.
Thank you. Sorry, it was a bit slow unmuting earlier. I just about fit under the 35 category, so still young-ish, and glad to be involved and continue to be involved. But I do welcome this paper. We've talked through some of it through the Alliance Committee as well, and I do think we are turning the ship in terms of better engagement, and Pam alluded to that, and hopefully Myrna feels that a bit more. And the co-production outlined in this paper is absolutely vital. In terms of sort of younger demographics, I do think accessing digitally is part of the future, compared to taking time to go and visit a PPG or something in terms of a forum. So we do need to look at that, but ways that are dynamic and engaging. I think we almost need to sell our services more, in a sense. And what I mean is, do you realise who is providing this for you, and can you give further engagement back or feedback back on the services that are being provided to people? I think that's how we engage patients and residents and our people, by actually saying, this is who's delivered your service, this is why we do it, and this is who we are. I think sometimes we don't do that, and people take and move on and get supported by the NHS and just almost believe that that's their right, which it is. But I think we need to show what we're doing and who we are, and invite them to feedback.
Mark, I hate to disappoint you, but you're old by the standards of us looking for young people as well, so join the club. Pam.
Yeah, just very quickly, it is referenced in the table in the paper as the last item, but Let's Talk SNE is a product that really goes to that message, Mark, that it's an online platform. And actually, I'm always surprised when we launch something on there how much content we get back. It works very different to website platforms. It's much more interactive, and we're able to respond and generate comments. And that is certainly something that we're using for the neighbourhood teams as we're developing them. And it's reaching far wider than we have felt with other engagement campaigns, and supporting that co-production.
Mark, sorry. To come back.
Sorry, yes, thank you for that, Pam. I wanted to come back actually because I forgot to say one of my other points, which was, and it was referenced in a discussion in an earlier meeting, again from Pam, about jobs and supporting the wider determinants of health. And I do think that's another way that we need to engage. So when we are doing work that straddles across jobs, housing, and the determinants of health that affect that people don't understand as much, I think we need to bring people in at that point. So I think that needs to be looked at when we are developing, for example, at Clacton Hospital or any other sites, that we're supporting the wider determinants of health, bringing people in, and the academy as well. Through that, can we get more people engaged? Because after all, staff are part of our population as well, and people who are engaging with our training programs or whatever else are still part of the patient population. Thank you.
There's lots of ways we can do this, isn't it, in terms of going out to people as well, and ask them to come to us. And I know we keep talking about things like going into schools. I think we've got a receptive audience almost, haven't we? So if we were allowed into schools, we could start using that as an opportunity to engage with some of the younger age group, because it's always the case that people that tend to engage more are those with health conditions or health problems or social problems that have had some interaction with the service, and that's great, but they're also, they have an agenda, but they've got something they want to talk about. Whereas those who don't necessarily have anything, but they're the ones that we miss out on, and maybe there's a way around that, but there are better people than me and more expert than me to try and tackle this properly. Myrna, are you on mute, Myrna?
Can't unmute.
You've muted yourself again.
Right, I'm ready now. You see, it kept going back on again. Yeah, I was going to wait for my report, which is the next item on the agenda, to bring a couple of things up. But I think as we're talking about it now, I'd just like to say that I think one of the best ways that we had with engagement was all the newer members will not have seen, because it was something that we haven't been doing since the pandemic, is having open meetings, and by that we had a lot of people were regulars, I have to say, and it was we tried having it in the evening to try and get the younger people to come. We also went into schools and talked to people in schools to try and get representatives onto the committee, and it just, nothing seemed to work, unfortunately, to be able to engage enough with the younger people. They still sometimes came to us when they were having problems, but it was to get them to sort of be part of the committee, and that was very difficult. And so we are probably a much older group than we should be, and I can see that that's not very representative, but it is very difficult to get younger people. I just think I volunteered even when I was working, doing 2 full-time jobs almost. I still did some voluntary work, but people don't think like that now, and it's very difficult to get them to come along and take part, and I'd hate to lose some of that. That was the true engagement when we got speakers coming out to talk to people. People were educated and learned a lot more, especially when there was new projects going on. And I think sometimes it changed people's minds about something they thought was going to be bad, and they were going to, it wasn't going to work. When they listened to people that were actually putting it into place and telling them how it was going to work, they changed their minds, and I think that's very good. And I really think we need to make sure that we've got everybody represented on the committee. And unfortunately, during the pandemic, we've lost some people because we're not having meetings. Not everybody wants to do the team meetings, and so we have lost a few people from the committee, which is really sad, I feel. And I just don't want to lose the real engagement that I felt that we had. I've been involved in it all my life, in engaging. And I actually think we actually were doing it very, very well at one time.
Thank you for your contribution. And I have to say, I think maybe it's this conversation offline coming, but it's maybe about the approach, isn't it? Because I know if I don't particularly like sitting in committees at this age, but if you'd asked me when I was 12 or 13 if I want to go and sit in a committee, I can pretty much guarantee you what my response would be. So maybe that's not the approach. Perhaps maybe it's just giving them an opportunity to comment, to reflect, to be involved, without necessarily having to come sit in a committee, because that can be quite intimidating as well, can't it? If you're the only person. So it's about, or maybe set groups up with peers. But like I said, I'm sure there are people more experienced than me at making the most of this. You said you had a couple of points. That was one. Is that your lot? Go on mute again. Get on mute.
I'm in real trouble with the mute today. No, I'll leave it if it's okay, and okay. Can pick it up in my report.
Perfect. You. As luck would have it, your report's next, unless there's any other questions. Right. Well, let's move on to your report. Keep yourself off mute. So,
yes.
Off you go, man.
Yes. Okay. Well, it's not been an easy time for us over the last few years, the same as it has for everybody, and I don't feel been doing the engagement we were doing before. It's been harder even to talk to the PPGs, because we're all given certain PPGs that we're supposed to keep in touch with, not just our own, and it's been difficult because they've not had open meetings, a lot of them either, and so it has the engagement part. I feel that all the new people, as I've said before, probably haven't seen some of the things that we were doing. And we did have very good engagement, I think, with all ages. And it's just, we're all a bit unsure at the moment, and that's why we've lost people. I think they're not sure what's going to be happening and everything else. And it's very hard to reassure them when you're not very, very reassured yourself. And so we've tried to carry on as much as we can. Oh, and I did talk to Lisa about having, trying to get some open meetings again, because I do feel people talk more at those, and we do find out more, what's really going on. And I think especially now in the Clacton area at the moment, when people are wanting to know what's going on with Clacton Hospital, and I'm pretty sure that most of the people would have known about it if we were still having open meetings. We'd have had people down talking, and we'd have had a lot more people coming along, because we would have advertised it and they would have known. And, they would be probably very reassured about what was happening at Clacton, because I think it's pretty good. And we could actually put that out there more. So we've been active, but not during the pandemic, but not to our usual selves. And I think some of the committee, nobody likes change, do they? Although I don't mind it, but a lot of people don't like change. And it's just part of life, isn't it? Really, change, and you have to adjust to it. And sometimes it's a good thing anyway. So it doesn't worry me, but I know a lot of people, we've lost people because they realise that things aren't going to be as they were, and they quite enjoyed the health forum as it was, and so we have lost people, and I feel now we're in a much weaker disposition than we was at the start of the pandemic, when we were going quite strong. But we're doing what we can, and sort of we're still having all the meetings, and we're still meeting with the PPGs, and see that, but that's dropped off as well. And it's like people have put themselves in isolation. I can't understand that at all, and they can't even sort of put themselves into a meeting. That's not hard, is it? It's not hard. If I can do it at my age, I'm sure they can, some of the younger ones. And it's just we're not starting now in what that we discuss in the future at the where we were at the start, you know what I mean, of the pandemic. So it's harder. It's harder, I think, and I'm just trying to hang on to the people that we have, because I know what good work they've done, and how, you know, especially our outreach people and that have gone to all of the fairs and that sort of thing, and put out about all the good work that's going on. Happy to answer any questions.
Thanks, Ben. I'm not sure that's a bit of a disappointing undertone to your report, really, to be fair. But Lisa, do you want to come?
Thank you. I just want Myrna mentioned that we met last week, because I like you, Hassan, was worried about you know, the undertones, really. So Myrna gave me half an hour of her time last week, which I was incredibly grateful for. And I think I'll summarise it, Myrna, but tell me if I get it wrong. But I think we've agreed that there are really three things that we need to do to support the forum. So firstly, admin support. So we're sorting that out. Even there's been changes of personnel and sickness, etc., but we really need to resolve that. I think, Myrna, you've felt that there has been less communication to the committee and to the forum than you have previously had. So people aren't quite sure what's happening. So I've asked Sophie to look into that, because particularly at the moment, we need to make sure that you are kept up to speed with everything. And Myrna is the font of all knowledge in Clacton, so gets approached by lots of people. And if Myrna doesn't know it, then who does? So we need to make sure we're supporting Myrna with that knowledge. And the other thing is, as Myrna said, the public meetings have been really, really critical to the Health Forum. So we're just going to look at how we can support you safely to have a public meeting in a very large, well-ventilated room, where we may have to we might not be able to have, you know, anybody can turn up, because we might want to restrict numbers. But I think we've kind of agreed a way forward to try and recapture some of that excellence that Myrna was saying they had before COVID. Thank you.
I think, I guess the challenge is how we combine this with a previous paper, don't we, to try and get a more positive outlook going forwards. And I think that's, I think once you marry this report to the previous paper, it starts to look a bit more positive, doesn't it, rather than the doom and gloom we're sort of painting. I think, you know, if we fail to get our patients to engage in some of our changes, then we're only going to develop services that really they're not happy with. I'm also going to pick up one little thing about the Clacton Hospital bit, because I don't know whether that's our responsibility or the hospital's responsibility, but are they not having big communication meetings, events? Because it's in the papers all the time, isn't it? So are there not events going on?
No, not events going on. You're right, it's in the paper all the time. But we would have had, if we were having the open meetings now, what we would have done, we would have had people come out from the hospital to talk to people about it, so everybody would know what was going on.
Yeah, but I don't really think it's for us to invite them. I'm not sure why, and it's such a big change and it's so important for the community. Why?
Because we're not having public meetings. That's why. And that's the only reason, really.
Okay. There's no reason why you can't have a Teams meeting, but Ed.
I mean, we've been trying to set. We've been talking to the PPG groups about it, you know, so that they know what's going on. But it's a lot of people there in the general public, you know, that still not quite sure. And it is such good news, isn't it? I think, you know, for Clacton, because it's going to make a big difference to people. So we want to get it out there.
Sorry, Ed, are you going to come back on the hospital?
Yeah, I mean, it's just to take an action. I mean, we could speak to James about setting up a public meeting. That's absolutely no problem. I mean, COVID permitting, of course, people may not want to meet in a big group, but we could certainly explore doing that, Myrna.
I think that'd be useful, because I know you said about the PPGs, but that's what, 50 people out of a population of several 100,000. So, you know, and I don't know, you know, even if you did a Zoom meeting, but at least if you did a Zoom meeting, you might get more people attend or listen than nobody. So and it is quite a big thing, you know, where you know, as you say, it's in the papers and it's getting some national press, and it's a great thing for the population. So if they don't know it's happening on their doorstep, then it's a bit disappointing.
I think one of the things is that the PPGs haven't been having their own meetings of their groups. They've been sending out newsletters and things like that, but they don't seem to have had public meetings. And ours certainly have. The committee of the PPG that I belong to, the committee have met, but we've not had public meetings during, you know, and I think we could now if with the right precautions, you know.
Yeah, well, I'll leave you to sort that with Lisa. And Ed, I think, yeah, that'd be great if you could have a chat to James about setting up some sort of a public information event or something, or at least an opportunity to engage with questions if there hasn't been one. I wasn't aware there hadn't been, but
I'll do that now.
So Frida, are you on mute, Frida?
I just want to say to Myrna that we've started our PPG meeting, so I think slowly they will start up again, hopefully. But as you say, it doesn't attract everyone.
Right, okay. Thank you, Myrna. Hopefully we got some positives out of that. Covered it. So move on to 22-23 planning. Is it going to be our headache or somebody else's headache, Jane? That's the question.
A joint headache, I'll say, Hassan, but thank you. So I'll take this paper in two parts, if I may. The first one, it covers really two issues, the first of which is about the planning and the work that's going on to put in place, as you say, plans for the new financial year starting later this week, actually. Golly, that's coming around quickly. And if Richard and Paul are on the call, they may want to come in on some bits of that. And then secondly, just to talk a few technicalities about next year's budget. So first of all, around planning, as it said in the paper, unfortunately, the timing of the governing bodies doesn't fit well with the national timetable for planning. We submitted our draft plan on the 17th of March. And that, as you've seen at the governing body before, is made up of a number of things. It includes a workforce plan, it includes a financial plan, it includes an extensive narrative talking about how we're going to deal with priorities, and it also includes trajectories for achievement of things like waiting list targets. Richard leads a planning group that meets every week on a Wednesday, and we've been coordinating that response across the CCGs and the system. In terms of the financial bits of that, we took a summary of where we're at to the Finance and Performance Committee on Friday and went through that. But it is a challenging scenario for the commissioning part of the NHS next year, whether we call that CCGs or into the Integrated Care Board later in the year. And the resources are similar to those received in the current year. It's effectively a kind of a doubling up of the resources we've had in the second half of the year without any of the non-recurrent additional elements that we've had. So we are working through those. And I'll just pause there in case Richard or Paul wanted to come in with any specific comments before I go on to what we're going to do about it.
No. We're shaking our heads.
Okay.
You're on your own.
So thank you. So in terms of actually getting sign off for that, unfortunately, we have to submit the final plan on the 28th of April, which is before we meet next time as a governing body. So in the paper, I'm asking the governing body if you are happy to delegate that. And I've suggested that we take the financial plan to the Finance and Performance Committee, which is due to meet in time for that submission, and other elements of the plan to come back to operational exec, because again, there's a meeting which is well timed for that. We will obviously be working through the alliance, because quite a lot of this is around alliance partners as well. But in terms of formal sign off, operation exec would seem to be would fit best from a timing point of view, if that's okay. So moving on, in terms of budget, we obviously, as a CCG, have to have a budget from the 1st of April, given that we've still got work to do in terms of settling the budget and finalising the plans for next year. The paper just suggests that we roll forward existing budgets so that we have something in place from the 1st of April. Obviously, once we've got to the point of having worked through and hopefully balanced our financial plan for next year, take over. But if the governing body is willing to do that, that means that we at least are legally able to operate from Friday. So number of bits in the paper that are effectively around delegation around the plan and the sign off of the rollover budget.
We're going to have to trust you guys, aren't we? But just one thing, obviously, the governing body's not till June, but it's first week of June anyway. Questions, comments, concerns? Martin, have you?
Nothing really to add. So Jane has already said, it's a challenging time ahead. In effect, the system is going to be in financial recovery, as I've already mentioned earlier on. And I think there's some tough decisions to make going forward. But it is what it is, and our existing team and then the ICB will need to really tackle this head on. It's sort of a lot of reminiscing on Friday about when about 6-7 years ago, when we were in a similar situation where we were spending more money than we had coming in, and the board had to make some incredibly difficult decisions around how it tackled that overspend, and that financial recovery was managed, and we tackled it head on, and we stopped some services, which was highly emotional at the time. It caused a lot of hard feelings and a lot of public anger, but we managed to get the financial system back into balance within a year. And we never looked back after that. I think for the next 6 or 7 years, we've met our financial control. We've attracted more funding, because in the NHS, success tends to breed success. If you're trusted with your finances, then you attract more money as you show you're competent at managing it. So it's not going to be for me, because I'm not going to be part of the new ICB, but I think good luck to all those going forward, and I just hope those difficult decisions are taken and managed effectively.
Tentative approval. Has anyone else got concerns, questions? We haven't got much of a choice, have we, really, Jane? Yeah, the only exception is that we then have an extraordinary meeting randomly at some point. But so if anyone's got real concerns, that would be the other option. Pam?
So I think it's important to recognise, in the way that we did this 8 years ago, this isn't a finance issue on its own. This is about all of us taking collective responsibility for it. And we've had the ability to put in some structure around programme management, and we're also making sure that we'll have a lens around health equity for this. So we can, obviously then make difficult decisions, but with evidence behind us and a set of principles that mean that we understand the ramification of the decisions that we're making. So I think it's important for the public to know that this is a very conscious approach to a financial situation, and obviously our quality colleagues, public health, etc., will work with us to make sure that we make good decisions in this space.
Next.
Did you say me, Hassan?
Yes, sorry.
Yeah, can I just, when we do with the plans that we put together, can we make sure, well, I'm sure there will be a lot of emphasis around workforce planning, because I think it feels to me, when I kind of similar situation many years ago, when we're actually going to get quite a lot of investment in the health service to try and recover the situation that we're in, in terms of all the targets that we're slipping on. So workforce is going to be absolutely vital to that. And I think we've got a depleted workforce, exhausted workforce, as I said before. And those plans that we saw, in the previous meeting, where lots of money coming into the system, but actually have we got the workforce to do that work? And I think at least for the future, over the next sort of 2 or 3 years, we need to really grow that workforce, don't we? And to achieve some of that, what we want to achieve.
Max, that's achievable, is it, Jane? Yes.
I don't know about getting the workforce, but there's certainly a detailed workforce plan both for the commissioning part and for all of our provider organisations across the patch.
We won't hold you to account. Amanda.
Thank you, Chair. Just to reiterate what Jane said, we have been working closely with our system colleagues over many recent weeks and months to make sure that we have got a fit for purpose workforce plan, which is very challenging. But in putting that workforce plan together, we are clearly linking that with the financial agenda and the transformation as well. So we are more aligned than perhaps previously. Challenging but doable.
Amanda. Paul.
Yeah, just to confirm again, we've also triangulated the workforce to the operational plan that have been submitted going forward in terms of waiting lists, reduction, etc.
Man, just need the people, don't we? So, right. So is everybody happy with the delegation of approval to F&P and OpExec with a final sign-off coming to GB in the first week of June? Then we're all still around. Okay. Perfect. Thank you, Jane. And then we've got safeguarding policy. Lisa.
Thank you. So this is just an update, a review, because obviously the other one, the previous policy was coming up for expiry. So once we transition to ICB, we will need to do a larger review to amalgamate both our Suffolk and North East Essex CCG safeguarding policies while keeping place-based arrangements, obviously where appropriate, but a lot of things are similar. So the policy talks about the framework we have for safeguarding, how we monitor, and roles and responsibilities of myself and the wider team. There were three updates that we've made to the policy. So we've updated the documents that are referred to within the policy. There's been an update of terminology in respect to the safeguarding partnership and child death review process, and there's been some more information in a flowchart for parental responsibility. So minimal updates. So I'm just looking for governing body to ratify the policy, please.
Anybody feel the urge to not ratify? No, perfect. In which case, consider that ratified. Thank you, Lisa. Richard, you've got a new model for us.
I've always got a new model, yeah. So this one is related to mental health accommodation. We thought it was important to bring this to the public governing body as it's a good news. It's absolutely a great change and model of care that we're looking to put in place across Essex. I'll just give you the headlines, Chair, and then I'm happy to take questions. So for those who managed to read the paper, the context is that we've got a commissioning responsibility alongside Essex County Council to provide suitable accommodation for those with mental health challenges, particularly those who are discharged from our secondary mental health providers. It's fair to say the model of care that we've got is quite dated now, and most areas are now looking to change and evolve what we've currently commissioned. So we've gone through quite a lengthy period of co-produced work with service users, staff and others across Essex to come out with a new model of care for mental health based accommodation, which you'll see on page 64 in the packs, moves away from a kind of a tier model to something that's more akin to intensive support for those who need it, but actually taking account of different levels within it, which is in the diagram, the coloured diagram there. You'll see that we've got a timeline really to move towards a new procurement for this model. So actually, this current service model expires in October. We're looking to go out then with a new model of care for these services. Timeline is there at section 2.1. The model of care has been developed Essex-wide, but at this point, Mid and South Essex has decided not yet to go. They need to do some further work within their local geography. West Essex and North East Essex ourselves would like to go ahead, so there will be a differential timetable to the procurement, but that actually is still fine. We're testing this within our local area, and we're confident we think it's the right thing. This has been through the North East Essex Mental Health Board, and it's also been through the North East Essex Alliance Committee. It's had support from both of those two forums. In terms of resource, Jane will probably go into a bit more detail. It's quite detailed in the pack, but in essence, there is an additional resource ask on a non-recurrent and a recurrent basis, which amounts on an ongoing annual basis to just shy of 500,000. That is funded through the existing pot that we've got, and it's topped up with community service development framework funding. So it's effectively covered within our mental health investment standard funding that we've got, and we are confident that it will see payback in terms of efficiencies further down the line, including reducing spot purchasing for capacity if we get this right. So effectively, we're asking the governing body for approval to endorse the new model of care, the new resource envelope, and to move now forward in partnership with Essex County Council and Herts and West Essex ICS to recommission and procure this service with an expected start date of October 22. Thank you.
Richard? Questions? I'll say it shows my naivety. I didn't know we had this responsibility until I read this paper, to be fair. So I don't know where it's been in previous years or just blanked over it, but useful to see. Max, sorry.
Yeah, thank you. Which looks really good. I mean, do you think it will actually have an impact on homelessness? Homelessness.
I think that could be one of the positive consequences, because we know through placement breakdown, etc., there is a corollary between homelessness and those with mental health and emotional wellbeing needs. So I think the model that we're talking about with intense support for those that need it will absolutely seek to address that, Max, and ensure that there's more of a sustainable solutions for those who are at risk of homelessness with mental health challenges.
Really good to see. Thank you.
You're on mute, Hassan.
I wasn't on mute. I'm not. Can you hear me now?
You're quite fuzzy.
Oh, sorry. Anyway, Pam.
Yeah, Max, to that point, I think the one thing we are focusing on at Alliance level is lots more consideration around housing with partners anyway. So utilising stock that is for supported living for the homeless, and recognising the link between the wider determinants of health and the impact poor housing has on individuals' well-being. So it's kind of like a full circle. This is not the only place where we're thinking about housing. We're using our alliance partners to regulate better, to improve the housing stock. So actually we don't get as big a number of homeless, particularly families, for the future.
Help me out, Richard, just for my curiosity. Was this bundled with something else in previous years, or has it always been a separate proposal?
It's always been a commissioning responsibility of CCGs. Lisa may add more. It's Jackie Bland has been supporting for some time. Particularly, a lot of this goes down into spot purchasing arrangements, but it's always been a joint commissioning responsibility of CCGs and PCTs before that, in terms of supported housing for those with. It's not everyone with emotional wellbeing needs. It is geared towards those who've got complex need, but it's definitely a requirement.
I'm sure it is if you say it is. I just wondered where it had been in the past, because I'm not. But maybe it's embedded.
I suspect, Hassan, that there's a number of, I mean, it kind of alongside the specialist placements and a number of our LD housing issues you're probably not cited on. Maybe we need to consider that, but there's a lot of work that sits alongside this around our transforming care programs across Essex and wider. So, but yeah, Richard's right. It is always been our responsibility as commissioners.
Yeah, I mean, again, just to be clear, I'm not questioning that. I think it's my own having not known about it before. It's hard to compare where we were before as to where we are now, and so that's all I meant. But
if it helps, Hassan, Jason in my team's come to support the item if there's any questions we're struggling with. So Jay's just put his hand up, so he might be able to provide more context.
Yeah, if that's okay, Richard, and afternoon everybody. Jay Joseph, Transformation Lead. you're quite right in saying that it's not something that's always recognised. What we've done with Essex Partners over the last month or so is set up an accommodation board. Emily's on the call today to bring together all the accommodation issues, because previously I worked for the county council where I led on support accommodation, and it always feels like it's more of a social care county council response than a health response. But in these integrated times, actually, when we talk about pressure on wards and out of area placements, this piece of work is intrinsic to the pathway, and special mentions really to Essex County Council, who have already looked at the relationship with districts and boroughs in terms of that conversation. So Cheryl Turner has been put in place to look at that move on conversation around housing. So it is about having an integrated pathway. One day, I think Emily's quite clear that she'd like to have everything down on one page to be really explain where people move in our system and how they're supported. And I think that would be a really useful thing for this board to reflect on.
Perfect. Thanks for the clarity, Joseph. I suspect it probably has gone to up exec or something in the past, and so maybe with the delegation minute, which is why it's never directly been cited on it. But does anyone have questions or that have been already asked, or wish to challenge the recommendation? Good. Silence is good. So we'll take that as approved. So I think we're okay. Not a text, isn't it? But it's essentially we'll approve the recommendation. Thank you all. Thank you, Joseph. And was it Emily you said joined? Thanks, Emily. All right. So questions from the public. I haven't had an email. I'll ask again if Simon's still about.
No questions received yet.
Okay. Bit disappointing, isn't it, really? But hopefully we'll have some face-to-face meetings at some point in the future where people can think of questions. So let's move on then to operational reports. So you're up first, Paul.
Yeah, so thank you, Hassan. So just a few things, a bit by way of preamble. So firstly, you'll notice that within the report, the BI team are playing with a new tool called Power BI. So they're starting to present information a little bit differently, which I think will help us to start sort of intelligently looking at the data, looking at performance. But more importantly, a lot of that data feed will become to almost real time. So again, rather than waiting a couple of months' time, we'll have some much more up-to-date information as we move forward. So again, quite a useful development as we move forward. So again, any offline comments around what might improve it will be greatly appreciated as we move forward. At the time of the report, there was an expectation that as on a national level, we will be de-escalating from a level 4 incident, a level 4 to a level 3. Sadly, that doesn't happen, and we remain in level 4. So I'll go through as to why that is and why it's important as part of the context of this report. The other, just a quick couple of things to say is clearly this report has been discussed at the Finance Performance Committee, and Martin, you may wish to add a couple of things if we missed in terms of that particular issue that we discussed. And finally, you'll notice that whilst we are mandated in terms of pressure to deliver a certain aspect in a level 4, my colleagues around the table have been working doing much more than that. So again, they may wish to contribute on certain elements. So again, if I may, Hassan, I'd like to just pick up on a couple of areas. One is urgent care, and the other one's the elective in particular, and to paint a bit of a picture as to where we are. So, as a system, we've managed to maintain what we call the OPAL level 3. So essentially, it's the second highest from the top of the level of alert and pressure onto the system. But what we've seen in the last week or so, and is detailed in the report, you'll see that back in sort of the 9th of March, sorry, we had about 97 COVID positive patients in our hospitals across the system, and that was in comparison to about 187 patients in January. The figures as we stand yesterday, 319. Again, it's important to stress that these are not necessarily patients who are being admitted because of COVID, or patients who have COVID following admission, or maybe there has been some spread of COVID within the hospital site. But I think the important point here is that it is causing significant operational difficulties within the hospital site in terms of patient flow, in terms of safety of patients, and to the front door performance. So again, we shouldn't underestimate the impact that is having. Similarly, in terms of workforce, it is having significant significant impact across the board. So whether you're talking to primary care colleagues, or whether you're talking to transport, whether you're talking to hospital site, we are seeing really high level of sickness as a consequence of COVID, and we are still waiting for IPC guidance to come from the national team. So again, we are operating within the boundaries of the operational guidance that we've actually got at the moment. So again, we find ourselves in quite a difficult position as a system, and that is really what's the word I'm looking for, is looking at the where we are to the OPAL level 4, so OPAL level system, and in the last couple of weeks we have declared an OPAL level 4, which is unheard for us as a system to do that. And the last couple of weeks we've been on OPAL level 4, at least on a couple of occasions. So it's really important to state that the alliance partners have been working really hard to try and keep patient safety at the highest level in terms of our mindset. But what you can see within the report is we are seeing some increasing delays in ambulance offload. We are seeing increased delays in C1 to C4 performance, which as a system we deem as unacceptable. So we are working very closely with our partners across system to try and do everything we can to mitigate any of those risks. But it is fair to say that we are in a really patient safety environment at the moment, not necessarily in terms of performance, whilst we are seeing as performance being fairly unacceptable. So I guess the picture I'm trying to point to is that when you look at activity and performance, ambulance conveyancing has not particularly gone up, attendances have not particularly gone up, but what we are seeing is COVID being as a consequence, and workforce being an absolute significant impact of what we are experiencing at the moment, and a likely consequence that from a quality and safety point of view. Just quickly moving on to elective recovery, because I think it is an important context. When you look within the context of what I've just described, our providers have managed to keep activity which are broadly within tolerance zones. So in other words, they've managed to keep a highly high level of productivity despite all these challenges, which is actually a testament to our staff and our partners within the system, and to primary care, to keep the show on the road, essentially to make sure we try to recover some of our waiting list, as Max has actually already pointed out, and I'll give a bit more detail on that. When you sort of cast your mind back a little bit and start looking back at system level, we had something like 7,000 plus patients back in April waiting, over 1 year. That figure stands about 3,900, just shy of 4,000. So against whilst it has plateaued recently, we have made some significant progress in reducing that over 1 year waits for patients. Despite that, our waiting lists are carry on growing. That's in part because we are focusing on our urgent patient and our long waiting patients, and patient numbers are starting to grow, so we're keeping a watchful eye on that. And I'll come back to that in terms of forward planning in a minute. We can see that there are still some inequity in services, so specialists of urology, TNO, gynecology, ENT are showing large amount of inequity of access across the system, and in particular around the West Suffolk. And the important element of that is that there is mutual aid happening across the whole system, and we are seeing some improvement because of mutual aid. So in answer to an earlier question around reduction in long waiters, we are seeing some long waiters not moving quickly as fast and in SNEFT because they're supporting West Suffolk and certain specialities. And just to directly answer Max's question earlier on around over 104-week wait, absolutely unacceptable. We wouldn't want any of our patients to be waiting that long. But a number in terms of for SNEFT in particular, and the last count for Mary's took at 36 patients. The large proportion are what we call OMF patients, which are oculomaxillofacial patients, and there is absolute confidence that by the end of June, from an SNEFT perspective, we will not have any 104-week wait patient by the end of June, and I'll come back to that in a minute. So an absolute focus on reducing our long waits in terms of our waiting list. Diagnostics remains a challenge, and the document actually points that out. We continue to work very heavily with our independent sector, and you can see that from the paper. And I'm sure Richard might want to touch quickly based on cancer shortly, which is also some relatively good progress in terms of how we're managing cancer. So moving forward, in terms of the earlier conversation we had around planning, just to take that in a square on, We have just submitted a plan to region into 22-23, and that plan does a number of things. First of all, it commits to achieving 110% of activity against baseline 1920, so a significant increase in productivity across the system. It commits to achieving 120% around diagnostics, again, including productivity and capacity, albeit there is a few issues around endoscopy, which we're working through. It commits to significantly reducing our over 78-week patients, and the aspiration being no 78-week patient waiting by the end of March 2023. We are nearly there. There are a few, especially where we don't think we're going to get there, but we are carry on planning to see what we can achieve through mutual aid and other approaches. And essentially, we are now having to start to think about our longer plan in term 2 to 3 years in terms of the impact on our waiting list and things we need to do moving forward. So I think what I'm trying to paint really is we are in quite a difficult position. We are not the only system in that position. The vast majority of the systems around us have been in level 4 for some time. It is unusual for us to be in that position. We are working to de-escalate, and we are managing to keep the service up and running and open to patients. And I think, Martin, at the meeting, you made a really important point, I think, which was to say the clear message we need to give to our patient and our public is that we are open for business. And if you have a need, we're there for you. But I suspect what I would caveat that by saying be sensible the way you use the services, because the system is actually under significant amount of pressure. So I'll stop there, and I don't know whether any of my colleagues would like to add anything to what I've just said, but essentially, Martin, is probably what we spend most of our time discussing at the FNP this week.
Paul, quite a long update. If my computer's playing, am I on mute?
No, can hear you.
Oh, perfect. All right. Lisa.
Thank you. I was just, when Paul was talking, I was thinking about it's always a challenge to know how to manage how to oversee the quality of care in a time like this, because actually what we usually see is not a massive increase in incidents, although we have seen some increase in incidents. We see a decrease in the effectiveness of discharge planning, a decrease in an increase in complaints. We see decrease in infection control compliance, because our workforce, particularly in the acute sector, are really very focused on the patient safety aspects and the delivery of IV antibiotics and things like that. So the things that add value to our work, so talking to patients and families to understand, discharge arrangements a bit better, don't always come through as outcomes that we can track in quality, but there are a few. And I don't know, Paul, it might be worth tracking our readmission rate, because that might be something where we see you kind of get into this loop, don't you, where we get poor discharge planning and then people getting readmitted. That might be something worth tracking. But I think it would be helpful to have a bit of a think about how we will, what are we actually looking at to understand whether quality has, we can assume quality deteriorates when we're under such pressure and our workforce is decreased, but it's really difficult thinking about what outcomes we will use to track that.
Richard.
Just a little bit more on cancer. So I'm looking at my other screen. The good news of sorts is that we're across the ICS, we're now 115% of pre-pandemic levels in terms of our referrals coming through into secondary care. So there's far more coming through than before. But we know we need to catch up given the challenges we had, particularly during the first 18 months of the COVID pandemic. Also at 110% of pre-COVID levels of treatment. So effectively, ESNEFT and West Suffolk are doing far more than they were before to try and get on top of the extra demand that's coming through from those 2-week wait referrals. But I think that's just to give the context of, from a performance perspective, you can see partly why the trusts are struggling, and indeed all trusts are struggling around meeting those key standards, particularly seeing and treating within 62 days, which is the key one. You may have spotted, some of you, that there's a consultation that's been launched across the country around changes to the cancer waiting time standards. So at the moment we have 9 that we track, including 2-week waits. So from GPs or professionals sending in to be seen in 2 weeks. They're actually going down to just 3, which is 31 day standard, 62 days and 28-day faster diagnosis. So the 2-week wait standard is currently out the consultation to go in terms of being a hard KPI. Locally, we're still keen to try and overachieve and keep our ambition higher than that 28-day faster diagnosis. And we had a meeting across the ICS through it's called SOAG, I can never mind what it stands for, Paul, but effectively the Performance Committee for the ICS, where we did a deep dive onto cancer, and there was a collective, I think, agreement that we needed to do more and not just stick with the national standard around these areas. ESNEFT has got some of the highest referrals numbers in the country. It's always in the top 2 or 3. So again, it's just to give the quantum of what the trust is doing at the moment. And just to give you comments, we've got the cancer board that meets on a bi-monthly basis, and the operational group that meets every month, that's overseeing not just our cancer performance work, but also our wider change work that we're doing across this, which includes Alice Parr, who's our clinical lead for North East Essex, who's doing an amazing job as part of the team on this.
Do you want to come back on any of those points, Paul, before I bring Max in? No? Okay, Max?
Yeah, I mean, I think, to be fair to ESNEF, I think they are doing relatively well compared to other trusts in the region and even across the country. I think there does seem to be a big focus on cancer management, which I think is obviously very appropriate. But obviously, I think the point I made earlier was that, you know, the other sort of treatments are suffering, I think, as a result, you know, and the non-cancer weights are what's really, you know, what even the cancer weights are bad enough, but the non-cancer weights are what is really concerning in terms of their sort of very high levels, I think. And I don't think it's an ESNEF issue. It is a national issue. It's not an ESNEF issue, really. Although I think Lisa's right. I think keeping an eye on quality is probably quite appropriate, actually, because I mean, I think the pressures that they're under, you know, you want to see that we don't get sort of problems with quality as well, in addition to waiting, you know, as another performance indicator, if you like.
I mute again.
Yeah, we can't hear. We're only hearing intermittently, Hassan, I think. I need to turn your video off. Well, we like seeing your face.
Maybe that's a problem. Yeah, Paul.
Yeah, it's just to say, Lisa. So because as you know, I chair the MSK group across system, and we are looking at readmission rate as part of our benchmark, particularly around sort of looking at how we benchmark across the region. So again, but I agree, I think we need to go much wider than that and do that absolutely routinely. And Max, just out of interest, if you look at the 92nd percentile of our long waits for ESNEFT, we're down to about 38 weeks. So essentially you see that ESNEFT in comparison to West Suffolk, because of their different sort of organisation in the sense of size and everything else, have been moving much more quickly than West Suffolk because of other structural issues at West Suffolk. But again, it's moving quite quickly. But I absolutely totally agree with you. We need to do more as quickly as we can. One limiting factor will be capacity, both in terms of physical space and workforce.
I'm just going to keep my camera off a bit, if that's okay, until my signal recovers. I can have my sound at the same time. Ed?
Yeah, just coming back to urgent care, Paul, and I know we're discussing this a lot, and the best thing that could happen would be to see a fall in COVID infection rates. But are there any particular additional actions we could be taking that we aren't? I mean, I was thinking about the East Perfect Day, the main events we ran in December. Are there any particular intensive things we could do to get us through this difficult period?
Well, there's a number of things, Ed. I think for a start, we are waiting publication of the infection control guidance, so that would be quite a useful to understand where the thinking is at the moment. I suspect it will be guidance, and Lisa, please correct me if I'm wrong, but at some point we would then have to review what that guidance looks like and do our own risk assessment, what that means and how far we're willing to go in terms of safeguarding patients. there is clearly a wider context in terms of consideration around, delays at the front door and the consequence of that versus consequence of VIPC and infections. So again, a lot more thinking around some of that. We are certainly supporting our providers and our colleagues in terms of infection control advice, with public advice where it is appropriate. And I would say we are also working with our local authority colleagues in terms of discharging patients and what we call designated sites. In other words, sites that have got proven, infection control measures to look after patients who have been exposed or have COVID to try and maintain patient flow. It's a really difficult position because essentially I think the COVID number are probably a representation of the amount of COVID that are there in the public domain, not necessarily an impact on infection prevention issues. And I think sort of moving forward, I think we will have to have that conversation how we balance the risks in terms of how we operate as a system vis-a-vis the population, and a clear national message. So again, I think we are probably doing everything we can at the moment. Ed, the only sort of light at the end of the tunnel, I guess, is there is a view that in the next 3 weeks that might peak. Now there is some scientific reason behind that which I don't profess to fully understand, but hopefully those numbers will start to drop if we are to believe that evidence. Lisa, I didn't want that I wanted to add anything in terms of infection control, but that's probably the level of my knowledge.
No, I will be awarding you an infection control master's degree, Paul. Well done. I think it's going to be. I don't suspect there'll be a huge difference in the new guidance, and I think it will be a discussion that we want to take as an ICS around what our risk assessment and processes will be across our 3 hospital sites moving forward once we've received that guidance.
Good. Martin?
Yes, Hassan, I don't really want to add anything to what Paul has already been through, because it's totally comprehensive and covered just about everything we talked about on Friday. One thing I would add, though, is it's very easy to be pessimistic when we're talking about 2-year waiting lists on some specialisations. An awful lot of, when you dig down into the figures, a lot of the waiting lists are a lot lower than that. The average waiting list is 9 months. But I think the most important aspect for me for this is very much something Paul alluded to earlier, which is the NHS is an incredible organisation and it's open for business. It's full of incredible people working incredibly hard. And if you do have an urgent illness, if you get cancer, as Richard has just described, if you have a heart attack, if you have something which needs urgent treatment, the waiting times are really not that much longer than they were pre-pandemic, which is testament to the incredibly hard work that's going on. So I think it's very easy to be pessimistic, but my glass is always half full. And so whilst obviously trying to regain the elective work is obviously a main priority at the moment, I don't think we need to be too overly pessimistic about the way things are going. And hopefully, as we get on top of the pandemic and things get better, we can start getting back to those long waiters and starting to make things a lot better. That's all I wanted to say.
Thank you, Martin. And just before you come back, Paul, so I asked a few times, and I think I had asked Lizzie when she was preparing this report, but it wasn't enough time for the report. But I know you've said systems adjacent to us are feeling the same pressures, but what would be really useful is definitely, if you could, for next board, maybe just for the item, maybe the RTT section, just us have a comparison, not just systems near us, but perhaps if you could just take a handful of systems in the rest of England, because anecdotally you do hear that the weights are better in other areas, and I just want to understand whether that is the case or whether it's just gossip. And the other thing is not to drill down into operational stuff, but I'll just, one line in the report was around MRIs, I think, and saying that the activity was growing and additional capacity, I think it said, is being sourced. And I just thought, we've had a whole conversation about CDC and then increasing capacity for MRIs. So why is it that we're still sourcing additional capacity? Is that not enough for us, or what are the thoughts around that? That's all.
So if I can come back on that, we do have sort of regional data set that benchmarks us in terms, particularly around say RTT, and from memory, I think SNE is actually the top in terms of benchmarking in terms of RTT performance. Now, in some respect, you can take that with a pinch of salt, because we don't want to be there. We want to be much better than that, I guess, because it is only measuring us against the rest of the regional system. Similarly, it benchmarks cancer, as Richard has already described, in terms of how we're performing. So happy to share that in terms of what's coming from the region in terms of benchmark. The bit that I was really amiss, and Lisa, apologies for, again, I'm treading on your toes, but I haven't mentioned vaccination. And again, in answer to Ed's question around our efforts around opening up vaccination for over 75 and 12 years and above, who are immunosuppressed, is quite key in terms of supporting and safeguarding our patient across system. So again, just to make a point that within the report, it also identifies how well we've done in terms of vaccination, but the work is ongoing.
Any other questions, comments? That was a good conversation. Thank you, Paul, for that. Note that report. Audit Committee. Jerry.
Thanks, Hassan. Yeah, very briefly, most of the committee, or at least a good part of it, was about setting up the year-end audit and planning for next year's internal audit. Apart from that, it was looking at some internal audit reports and approving debt management policy. Happy to take any questions, really, unless Jane wants to make any comments.
Have you any comments, Jane?
No, I think that's a good summary in the paper, but I am going to just come back in on the previous one, Hassan. I didn't realise that you'd finished the whole paper, and just to note that so for the minutes, that the CCG overall financial position is expecting to break even for the year, so which we spoke about at Finance and Performance Committee.
Again, we'll cut and paste that retrospectively. But on this paper, so no comments about the audit. Did you want to perhaps just take this opportunity to tell us what's happening with the Audit Committee going forwards? Any changes or proposals? Or
so obviously we Audit Committee has a large role in the accounts, so we've got various different meetings set up for that. We meet again next week to look at the Head of Internal Audit opinion on the accounts for the 3 CCGs, and to start the year-end process. There's a timetable paper in there for that. Going forward, we need to kind of look at exactly what the timings are around the formation of the ICB, because if it's a part year, then there will be a separate accounts to approve, again, which is part of the Audit Committee. But I hope I'd reflect views of Audit Committee members on the call, that the arrangements for meeting in common seem to be working pretty well across the 3 CCGs, so I don't have any proposal to change that, and particularly as we're looking at the moment around a lot of ICB policies in preparation for the ICB. I think that doing that once, with having all the collective brain power on there, has actually been really helpful.
Thank you, Gary. Any other questions about the report? I'll try turning my camera on and let me know if it starts buzzing again. I find it quite disconcerting to be. Right, no other questions, comments? In which case, thank you, Jerry, for your report. Very grateful. REMCOM, or Remuneration HR Committee report. Sorry, Martin.
I'll take the report as read and just answer any questions. There's nothing really to highlight that we haven't already talked about.
Okay, thanks, Martin. Did you want to add anything, Amanda? Or
I don't think I did actually, Hassan. We've got our next REMCOM coming up next Tuesday, but no, the meeting was a typical Remuneration Committee meeting with their standard agenda items.
Okay. Got any questions they've been dying to ask? Okay, we'll take that report as read. Thank you very much, Martin. Quality, Lisa.
Thank you. So the Quality Committee received a number of reports, and a fair part of the meeting was actually talking through the urgent care SI framework, sorry, couldn't think of the words there, that we are introducing with eEast, whereby any system delay or delay to treatment that results in a catastrophic or severe harm to a patient is reviewed as a system, and the learning and recommendations are investigated and accepted by the system. So there was a good discussion around that. The issues to highlight, reflecting back on the safeguarding policy that we looked at earlier and our responsibilities to monitor safeguarding compliance within our providers, we have noted that the safeguarding training for the North East Essex Integrated Community Services below the acceptable targets. Now, that some of that is being driven by ESNEFT not accepting the competencies that were previously accepted by ACE. So the safeguarding team are just working with ESNEFT on that. So that's not looking great at the moment. Waiting time for psychology intervention in North East Essex is around 17 months. There is a clear, we heard in the report around the clear plan for recovery by the end of the year, but that is a concern for the quality team. The DCO teams across Essex have been working on understanding special school nursing commissioning, which I believe a paper went to the joint commissioning programme, which Richard co-chairs in Essex. But at the moment, we do have some concerns around the school nursing that's been commissioned in special schools in North East Essex. So just looking at that and liaising with public health, because obviously it's a public health commissioning issue. Talking about ESNEFT, I think the only thing I would want to highlight with ESNEFT is to draw your eye to their safer staffing data. So we were talking about workforce and the impact from COVID. And actually, when you look at their safer staffing data, you'll see that for both qualified, so safer staffing data is the percentage of actual shift fill against the required shift fill, and you'll see for qualified staff, they're both RAG rated as amber, which is quite unusual actually. And what you already have in there is your temporary staff. So actually, if you think about the substantive staff that are possibly within that percentage, it's probably quite low. So that is a worry. You'll see that the healthcare assistant is green, because I can see what ESNEFT are trying to do is to increase the care assistant numbers to compensate for lower registered nursing numbers. But as we know, that will impact on the things I was talking about earlier around discharge planning, patient experience, and some of those harder to measure nursing interventions that we see. So I think that's something we need to keep an eye on. The only other two things that we discussed at the Quality Committee was the initial health assessment. So Essex overall is quite low compliance against initial health assessments for looked after children at around 23%. In North East Essex, Q3 overall was 60%, so we are tracking higher than the Essex average. We were 100% in December, but there were six delays related to cancelled appointments and consent, which has brought our compliance down. And as we know, initial health assessments are really important quality intervention for looked after children to understand potential health issues. And I would just draw your attention to the fact that in CHC we're meeting the 28-day timescale from notification to eligibility decision, which is a really important thing in the context of such a busy emergency pathway. But thank you. Thanks, Hassan.
Any questions? No. Can I just ask, so with the tollgate report, I understand there's been a follow-up visit. So You're on mute.
Sorry, yes, there has been. We talked about receiving that at the next meeting. It was in February, Hassan.
Okay. We can't share.
I haven't. I'm not cited on what
okay.
that they were found.
Sorry, Max.
Thanks, Chair. I don't see any mention of North Clacton Medical Group, but there's been quite a lot of inspection and monitoring of that practice. I know, is that because it's not had a CQC rating, or but you know, is that not something we should be, or is that a part 2 item?
No, I don't think we did have a discussion around North Clacton, so we could absolutely. I can make sure that that's reflected back. Yeah.
Yeah, I mean, I think the CCG have been
sure. Yes, they have.
Very, very active with that.
Yes.
And,
yeah.
And
before I bring you in, Pam, was that in response to that? Okay, do you want to come in just?
Yeah, so there has been a visit. We're awaiting the final report before we can publish some of that, but just suffice to say the CCG is working closely with the practice and the CQC.
Thank you. Patience, Ed.
Yeah, my question is, there are going to be services commissioned by NHS. There are services commissioned by NHS England that will transfer to us by 2023, and I don't know, Lisa, whether with your quality monitoring you're starting to monitor, you know, the dentistry, the ophthalmology, the pharmacy, etc., as part of that review, or whether we should start to think about doing that in preparation for that responsibility.
Yes, I think we need to. I mean, this is part of the quality strategy as well. So actually, with such significant services coming potentially to be delegated to us, how will we robustly monitor and oversee, and what kind of oversight have they been used to with NHSEI is really important to understand. But it's certainly, we haven't really started looking into it hugely, but it's certainly something that we need to. It's slightly nerve-wracking around capacity, if I'm honest with you, because it will be capacity for the whole team. So certainly my designate safeguarding team are being asked how they will oversee safeguarding in those environments, and that's a massive ask on current resource. So it's not just about how we will oversee, it's about how we will use our resource in its totality, because it may be that we have to change the way that we're doing things. So but yes, it's certainly on our radar.
If there's no other questions or comments, we will note the report. Thank you very much, Lisa. I would normally ask Pam for comments, but Pam's not here. I don't have any other lay members. No, not you, Pam. Pam D, quality. But she's not about. And neither is Mark. I don't think Martin or Jerry go to quality, do.
No. And Mark and Pam, unfortunately, Pam couldn't make it, and Mark unfortunately was not very well.
Oh, okay. Assume they're happy in their absence then, or nothing else to add. Right, let's move on then. Sorry, Pam, I know you stuck around to do your reports.
Yeah, sorry, I do need to try and leave relatively quickly, so
I'm all for whizzing through.
Pardon?
I'm all for whizzing through. So
yeah, so most of them can be taken as read, but I just wanted to point out some notable improvements around the primary care reviews of severe mental illness health checks in my report from the Primary Care Commissioning Committee. Sorry. So this is a collaborative approach towards this issue, supported by GPPC, EPUT and our practices, and there has been a significant improvement around the SMI checks, which is really important for that cohort. So best progress we've had despite coming out the back of the pandemic. So I'm really pleased that that's happened. We've also maintained extended access, yes, with some vaccination capacity in the last quarter, but actually now that access is very much focused around general practice access. And we're doing a piece of work around opioid dependency with the STARS charity and supported by EPUT and ESNEFT. And also switches of inhalers. One of the biggest green things that we can do within primary care for meeting our carbon reduction is actually to switch the type of inhalers that we use. So we've got a program around that, and there's been some significant progress. So but also we have had outstanding results for the diabetic service between GP Fed, the Suffolk Fed, and our practices. One of the first truly integrated lead, I can't even remember what format we used, but it was years ago, contracting models, innovative contracting models we put out to the market. This board signed off. We were the lowest decile in diabetic care. At that point in time, we put services out to the market, and this model has truly delivered improved care for our diabetic patients, early intervention, reduction of amputations, and better management. And that the service in the last few weeks has been highly decorated for its amazing results on the national survey. So I can't deliver this report without making reference to those achievements.
So just to be clear, you were just talking about your primary care commission report. You haven't taken everything as read. We're still
no, just
some
primary
sort
care
of order,
commissioning report.
Fine, okay.
I'll do them in order.
Fine.
I just want Hassan just to remind you there's some terms of reference that need approving on there as
yeah,
well. Yeah, no, that's all right. I just
sorry. I know what I'm doing, Joe. Sometimes. Thanks for keeping checks on me, though. so
that's the first.
That was the
report.
overview report, wasn't it?
Yeah.
So any questions about that content, the overview report from anyone? In which case we're asked to note that, and then your next one is obviously to approve TOR, isn't it? So
the terms of reference from the Primary Care Commissioning Committee are to keep us going through this transition phase and ensure that we have signed off set of terms of reference for us to do business. It's the committee that oversees primary care, of course, and it is held in public. So these are an important set of terms of reference for our delegation from NHS England as it stands currently.
No, the only point I was going to make, it's as it stands currently, isn't it? So whatever happened in the new world. So for the time being.
Yeah.
So anyone got questions, comments, concerns? I think you've put in the guidance from NHSE around the TOR as well.
Yeah, the delegation guidance is at the bottom of the terms of reference.
And who's written these TORs? Is it?
So they're from the original ones that I wrote when we first set up Primary Care Commissioning Committee, and they've been edited by the committee and signed off by the committee.
Perfect. So unless there's any questions or challenge, or is there a comment on there? Okay, Max is singing the praises. Right, so everyone happy with terms of reference? Perfect. Thank you. So now those are the two, wasn't A and B, and now we're on to the Alliance Committee overview report.
Yeah, so I really don't want to just take this as read because there's such a lot in this report around the work that the Alliance is doing in all of its domains, from start well to die well. But notable achievements in the last few months is the mobilisation of the integrated teams for Colchester. And we have run numerous multidisciplinary teams now, and we're taking referrals from police, from district and borough housing officers, all sorts of things, and starting to really target those complex cases that we are presenting a challenge across all partners. Really good feedback in the way that the team are developing as a team, and we're giving them a significant amount of organisational development to ensure that they're got good, safe practice. There's a range of leadership across that that team, from the voluntary sector to ESNEF to our mental health trust, and there is engagement. I'm not saying it's perfect, but there is engagement from the GP practices. We need to keep working on that as we mobilise more practices, but there's good outcomes starting to come to fruition there. So it's been a massive piece of work that we've managed to keep going despite the operational pressures, and it's leading to a really good framework across the patch.
Really encouraging to see, actually, and it's nice to read a report, to be honest. Questions?
I'll take any questions on it, though. I'm not really doing it justice by going that fast through it, but
Ed.
Yeah, just absolutely brilliant news, Pam, on the neighbourhood team. Could you just remind me with the team in tendering when that's going to be up and going, if it isn't already?
So it isn't at the moment. We hope to appoint to the connector role by the end of April, and we will go live with the first South tendering team from the beginning of May.
Brilliant. Thank you.
Else?
Nice. Sorry.
Okay, back to you.
Can I just ask?
Yeah.
So with the neighbourhood teams, have
Yep.
they kind of got? And maybe I'm just not up to date with it. Have they got sort of management structure within the teams? Are they actually forming their own kind of like little management groups? Is that what's happening? Yeah,
and that's a collaborative sharing of responsibility across the patch. So you won't see the same organisation in the same role in each team. Right. It depends on the challenges and who's come forward, who knows the patch best. But that's what I say. We've got connector roles, so connecting health with all of the other partners, and some of those are from the voluntary sector, some of those are from ESNEF, some of them from EPUT. At the moment, they're the organisations that have put people forward to support bringing together the teams and the integrated working. England and Active Essex as one of the activities to support mental health and wellbeing. You know, all sorts of different resources coming into those teams.
Also win the award for the most bizarre pose on frozen screen. So.
Oh, did I? What did I do?
Something like that.
Was
right.
I still talking, or did you lose that as well?
No, you were still talking, which is what made it entertaining, and which is why
I did wonder why you all laughed.
Sorry, not to distract from paper. But no other questions? Okay, sorry we're whizzing through these, but thank you. That's for noting, wasn't it? I think that paper. So
there's lots in there about levelling up and the relationship with the university and all the stuff we're doing as outreach, but that could take a whole meeting on its own. So I'm happy to bring a more detailed paper update on that when the time's right.
Well, I think, you know, there's a lot in there and a lot that many people won't understand. So it's, I guess it's just, but I'm sure you're happy to answer questions outside.
Absolutely.
If they have them for clarification. That'd be quite useful. Perfect. So procurement.
So so this is the usual procurement update, taking you through the procurements that have been delivered, those in the pipeline, and those that are pre-pipeline. You'll see that there is a significant amount of Pan Essex procurements ongoing at the moment. So working with Attain to ensure that we have coverage in all of those procurements that are going quite intense at the moment, but we're also working with Attain to ensure that we're ready for any changes around the collaborative procurements for the future. So it and the provider regime, which will change the way that we procure when that law is changed. So at the moment we're proceeding under exactly the same guidance as we always have done until there is a legal change in how we can procure. But we're making preparations for that and ensuring that our policies will fit.
Any questions? Can I ask a real quickie, and you can answer it outside of the meeting if you've got to
Yeah.
go off. It's just really an operational thing about advice and guidance. Obviously, we've got an advice and guidance contract, and Consultant Connect is running out in 2 days. But we've also had emails from the trust about how they're withdrawing some specialisms from advice and guidance. So everyone's a bit confused about who to go to where. So
yeah, one of my team is working on that at the moment. It was a surprise that we were going to be receiving that information about not being able to access the trust advice and guidance, and it's resource driven, but we're going through a process to try and reinstate some of that, because actually it drives away the demand if we can get it right. So we're in conversation about that at the moment.
And just some clarity for everyone out there who's thinking what's happening next, where do I go with them, would be useful. Okay.
Yeah, the contract is being ceased with Consultant Connect. That was a very conscious decision from the way the engagement with the trust had gone. So
yeah, no, and that's why I'm raising it, because I know that we might be left with nothing, and then obviously that causes pressure on urgent care services and outpatient referrals, etc. as well, doesn't it? Sorry to pick on something so specific. Paul.
Yeah, just to add to that, each individual trust has just submitted plans to region to maintain advice and guidance if anything accelerate its use. So I'm a bit confused by that conversation, so we can pick that up offline.
Okay, perfect. Thank you. Any other questions? In which case, thank you for the update, Pam. And then this is your last one, I think, isn't it? We can disappear. Yeah. APC.
Yeah, so again, this is the area prescribing committee, pan ICS approach, very clinically led, not the easiest of home for it to report directly to board. We've always discussed that, but this is to ensure that that delegated function has the right governance and oversight from this group. So happy to take any questions, but we usually don't debate the clinical content of these at this committee, at this board, sorry.
We don't. Only a few of us can. But any questions, comments? No. Okay. In which case, thank you for that, Pam.
Thank you, and I'll leave you to it now if it's okay, so I can go to the other meeting. Thank you.
Your contribution so far. We're nearly there anyway, I think, aren't we? I'd say it properly. COVID Resource Approval Committee, Jane. Oh, am I muted again?
No, you're not muted. Do you want me to cover this one, Hassan?
The CRAC committee, your names are up against it.
Yeah. So this is the regular update of what's been approved at the COVID Resource Approval Committee since our last meeting. We did go through a slightly more detailed report at F&P, but you can see in the paper the decisions that have been made since last time. So happy to take any questions.
Oh, sorry, go.
Sorry, and the second part, yes, which I had just about forgotten, but we're also on the recommendation of CRAC are asking to continue the committee until the formation of the ICB. We call it very rarely now, but it's really to do things like the vaccination programme, and obviously if we are seeing an increase in COVID cases, we may need to make some quick decisions. So if the governing body is in agreement, I'd just like to keep it there in the background.
Feels like one of those committees that we keep extending because we're about to disappear in a few months, and then hey ho, we're still here. So any questions, challenge, concerns about the content? No? Okay. Let me try putting my camera on again. I really don't like it, but there you go. So that slows it down. So we're asked to note the report and approve the extension, which there's no questions, I gather we're happy to do. Okay. Everyone's just tired and exhausted now. Bear with me. Amanda.
Thank you very much, Hassan. So the Governing Body Assurance Framework has been updated since our last meeting. We have got one new risk added this time around this CYP agenda, which Lisa may add to, but I just wanted to update on the cyber security risk, and there has been a lot of active work over the last 4 weeks, particularly in light of the events in Ukraine, which has resulted in our IT team and our IT provider AGM really doing as much as possible to prevent any future cyber risk. So examples of work recently undertaken is increased communication out to our staff to make them aware of what to look out for in terms of unusual emails. We also forced a patching of our system in the middle of March, which I think went very well. And we continue to work with AGM, as I said, to ensure that they continually monitor as part of the IT contract. So all in all, I think in terms of cyber, which we do report periodically to the audit committee, we are managing as best we can in terms of that. Attached to the assurance framework, we also have the updated local risk registers that we continue to monitor and review at our monthly risk forum. In terms of the other risks that are mentioned, I think a lot of those have been mentioned throughout the course of the this afternoon's meeting. But I'm very happy to take any questions, Chair, or indeed other directors may want to add in terms of their risks that they're locally managing. Thank you.
Have we got questions first? Okay. Do any of the other directors want to add? No? Well, I can only see Jane, I don't know if anyone's got their cameras off. Lisa.
Well, no, so I'm happy to just update around the risk that Amanda referred to around children and young people with acute mental health crisis. So it has been raised by our Colchester site of ESNEFT as a real quality concern. So over the last few months, we have had up to 4 young people on the Colchester site with an acute admission requiring mental health support, either under a Section 2 or a Section 3 of the Mental Health Act. And it's been a real concern to us as a system, but also obviously to ESNEF to be able to provide the right environment and the right treatment and care. And we've had amazing support from NELFT and, there's been a lot of wraparound, but it has resulted in one young person remaining at Colchester site for over 150 days waiting for mental health treatment. She has now gone to an appropriate place to receive that care and treatment, but we've had some really concerning times across the system. So we have a CYP mental health group, which Richard is chairing because he just does it so amazingly fabulously. And we are looking at, so we're really quite clear on the medium and long term actions that we're taking to try and support mental health crisis and to try and make sure that children and young people have access into mental health support. But some of the things that we've been working on around short term that have come from our acute sector. So actually how can we support them with the right workforce? How can we make sure that they have mental health practitioners employed within ESNEF to support the team? So we've been doing some work, and Richard's been working with ESNEF. I'll let Richard talk because I'm sure he can do a much better job than me.
Thanks, Lisa. Just very briefly, so we had our first system-wide summit, as we called it, about 3 weeks ago, which brought together reps from, all main partners to kind of understand what the problem is we're trying to solve and start to try and seek some immediate suggestions on how in the short term resolve while we look at the longer term implications. Leanne Joyce in Lisa's team, who's Deputy Director for Nursing for Children and Young People, has agreed to take forward a specific task and finish approach. And they've met, I think, 2 or 3 times now to look at some concrete proposals that they're going to bring back on Monday under Lisa's chair, as I'm on leave on Monday, to look at how far we can take those individual proposals, which include actually working more closely with the BCSE sector, looking at some of our independent providers that might be able to provide specific specialist support for children and young people at that tier 4 tipping point. And also ESNEFT has developed a comprehensive costed proposal in the short term, how they might be able to put support wrapped around these young people while they are in ESNEFT, where they shouldn't be longer term, obviously, but while they are more support in. Bottom line is that we have a significant gap between demand and capacity. So at any one time, there's upwards of 40 to 50 CAMHS tier 4 beds closed across the region, and that demand is increasing, not reducing in terms of it. So we are in the position where we do have a waiting list on everyday basis, and the team that are supporting this across the region, the specialist collaborative team, are constantly trying to juggle the different individuals through a triage protocol process around getting placement. So the actions that Lisa and I are trying to take are, what can we do locally in the absence at the moment of that tier 4 capacity to support children and young people, while the national and regional team look at the longer term model for CAMHS in terms of what changes need to be made in light of the ever increasing demand on that kind of service provision.
Should I come back to you, Amanda? Do you want to finish up?
No, I think we've actually concluded, Hassan, in terms of the current framework.
Okay. Anyone got questions? No. Okay.
Hassan, you're very intermittent again.
Sorry, I'll just leave my camera off. Sorry. Thanks for the update, both. Amanda, sorry. And then we're staying with you, Amanda, aren't we, for the health and wellbeing update?
Brilliant. So this is our typical standard report on all things health and wellbeing activity across our CCGs. I think the paper is self-explanatory, but I will just highlight a few areas. We have 24 health and wellbeing ambassadors now trained across the 3 CCGs, and we have now an increase to 13 trained mental health first aiders. And we continually roll out a programme of health and wellbeing activity, and recent events have included workshops on sleep well and work well. In February and March, we launched a couple more networks, the Disability Network and the LGBTQ Network. And through the Health and Wellbeing group, we also link into Andrew Urquhart on the wider sustainability. And we are also continually addressing the staff survey actions of last year, which I think will provide helpful progress in terms of the staff survey that obviously will be arriving tomorrow, which I will be updating members on next month. So all in all, health and wellbeing activity continues. We have an active group, and I'm quietly confident that a lot of the work that we've undertaken over the last 12 months will be reflected in our staff survey results once we receive them. But very happy to take any questions, Chair.
Amanda, has anyone any questions? No? Okay, perfect. In which case, thank you, Amanda, for the report. So I think that brings us to the end of the agenda. I haven't been told of any other business. Does anybody wish to raise anything now? Okay. I didn't give you too long. In which case, the next meeting is Tuesday, 7th June. Now, I was hoping let me start again. That may very well be our last board meeting as a CCG. I'm not exactly sure whether it is or it isn't at the moment. I guess time will tell. But I was hoping if it was our last meeting that we tried to do it in person, because some of us might not be meeting again in that forum. But I don't really think, well, A, I don't know if it's going to be our last meeting, but B, given the rise in COVID numbers, etc., I'm not sure what everyone feels about that, whether it's appropriate or not. So I'll let you know, basically. But it would be nice if it is our last meeting, if we could meet up in